We know we still have patients in CML that will require long-term therapy. I mean, at a minimum, it's 3 years, I think we can say fairly at this point. And some patients, it's indefinite. And that raises the question of adverse events, particularly cardiovascular adverse events. And really, it's not that complicated. The best way to manage it is to think about it, to acknowledge it, to risk stratify as you choose therapy. Now, clearly, it's going to be most relevant when you're choosing frontline therapy because you have multiple options, and that is only one of the factors. When you're dealing with resistant disease, you may not have the luxury of minimizing cardiovascular risk as much as maximizing response and outcome. But still, with more drugs on the horizon, particularly in the space of third line and fourth line and allosteric inhibitors, I think we have some nice additions, particularly Asciminib, now offering an option for patients with 2 or more therapies and offering a lower risk profile and some new drugs still in development. So if we can recognize it at the beginning and make sure we choose properly and also risk stratify patients. So patients really deserve full cardiovascular evaluations if they're headed towards a drug with risk, if they're even headed towards a drug with lower risk, but they haven't been risk assessed as an adult. Many patients haven't seen their primary care or cardiovascular specialist, and if they can, they might be able to see a cardio-oncologist. So I think if we use all these tools, we really can minimize risk at the beginning, kind of manage it as best we can in the middle, and really hopefully keep it to a minimum. I don't know if it's going to go away. And of course, we have to keep following it as we see new drugs developed and understand what their risks are.